And start. Good morning, good afternoon, good evening, dear TORG members and participants to this webinar. We are great that we have the speaker of the day, Madam Florence FURAHA is here, and I think without taking much time, as you saw on the flyer, we are going to discuss a very important topic in the operating room, which is the surgical safety checklist. Let me go first and go through the biography of our speaker, and then let her start the presentation. Ladies and gentlemen, please join me in welcoming Madam Florence FURAHA, RN, BCN, Masters in Perioperative Nursing. It's my pleasure to introduce our esteemed speaker for today's webinar, Madam Florence FURAHA, a highly experienced and dedicated registered nurse who has made remarkable contributions to perioperative nursing in Rwanda. With 16 years of experience at King Faisal Hospital in Kigali, the very first accredited internationally hospital in the country, she has advanced to the role of unit manager for the operating room, where she leads surgical nursing teams and uphold the highest standard of patient care. She holds a master's degree in perioperative nursing from the University of Rwanda, equipping her with specialized knowledge in surgical nursing, infection control, and patient safety. Beyond her leadership in hospital operations, Madam Florence plays the pivotal role in mentoring and training the next generation of perioperative nurses. Her dedication to education and skills development has significantly strengthened Rwanda's surgical nursing workforce, contributing to improved surgical outcome and enhanced healthcare services. She is a key figure at King Faisal Hospital, where she continuously implements strategies to enhance surgical safety and efficiency. Her passion for nursing education and professional development extends beyond the hospital settings. She actively participates in the policy discussions, mentorship programs, and educational forums aimed at advancing perioperative nursing standards in Rwanda. Through her advocacy for best practice, she has played a crucial role in shaping the future of surgical nursing, not only through direct patient care, but also by influencing nursing education and professional training. Today, she will be sharing her expertise on surgical safety checklist at the operating room global webinar, providing valuable insights into improving surgical safety and teamwork in the operating room. We are honored to have her with us. We welcome her. Welcome, Madam Florence. The floor is yours. You can start the presentation. Thank you very much.
Yeah.
Hello.
Hi.
Hi. Thank you, Wilson, for the introduction.
Good evening, good afternoon, and good morning, depending on where you are. Thank you all for being present tonight to my presentation. Okay, thank you. So the introduction is that the surgical safety checklist is a tool designed to improve the safety of the patient undergoing surgery by reducing the risk of preventable surgical errors. The surgical safety checklist typically consists of 3 phases, which are before anesthesia induction, before incision is made, and before the patient leaves operating room. So patient safety is a key priority in surgery. As you all know, surgical errors and complications can be reduced through systematic checklists. The WHO surgical safety checklist is widely adopted tool. Here shared is the picture of that's showing how we should behave or how people are following the person who is doing surgical safety checklist. While doing surgical safety checklist, people should be attentive and listen very well so that we can just contribute together to just facilitate the checklist to be done. So this is the picture of surgical safety checklist we are saying. As you all know, as you may be aware, and as I have said in previous slides, I said that it has 3 phases, which is demonstrated here by different colors. The first part in yellow, it's sign in, and the green part is timeout, and then the last part is sign out. So we'll see in details in following slides, but while we are here, I'm going to mention about the difference about these 3 phases. Starting by the sign-in, here we have to identify patients by their names and procedures, surgical site, by consent. And then here we have to just check if the site is marked where applicable. And then we have to see to make sure that anesthesia safety check completed. And then pulse oximeter on patient and functioning. And then we have to know about allergy on patient, if the patient has allergy or not. And then we have to know before anesthesia induction, we have to know the difficult airway or aspiration risks to the patient. And then we have to know the estimation blood loss. So on the timeout, we'll see more details after. On the timeout, here the team confirms their cells by names and roles, and then the surgeon will then mention and verbally confirm the patient, the site, the procedure that is going to be performed. And then here they should mention if there is any critical or unexpected steps during surgery. And then they have to mention if there are any patient-specific concern during or after surgery. And then the nursing team will come and just confirm whether the sterility is confirmed, or if there is any equipment issue or any other concern. Then they have to mention if the antibiotic prophylaxis have been given or if not needed. And then depending on the procedure, they have to just mention, they should mention the essential imaging if they need like photos of the patients, especially for patients who are going to be operated on the bones for orthopedic or neuro cases. Going to the sign out, this is before patients leave the operating room. The nurse verbally will confirm with the team by asking the doctors to confirm about the procedure performed, if the planned procedure is the one performed, and then they will confirm about surgical count, then about specimen and other equipment related to be addressed. Surgeon, anesthesia professional, nurses will review the key concern for recovery and management of the patient postoperatively. So we can ask, why surgical safety checklist? The surgical safety checklist will help us to improve communication among surgical team and also to reduce errors and surgical complications, and it will enhance patient outcome and satisfaction, and also for safety protocols. Here we're going to talk about safety, surgical safety. The surgical safety refers to the systematic measures and protocols implemented to minimize risk, prevent complications, ensure the best possible outcome for patients undergoing surgical procedures. And also this one will involve preoperative, intraoperative, and postoperative precautions to reduce medical errors, to reduce infection, and also anesthesia-related complications. So here are 10 essential objectives for safe surgery. The first one is to ensure correct patients, correct site, and correct site of surgery. Prevent harm from anesthesia administration, control airway and support respiration, anticipate blood loss and hypovolemia, prevent allergic reaction, prevent infection, and count surgical instruments and sponges, identify surgical specimen, communicate and exchange critical patient information, and also surgical surveillance. So the importance of surgical safety checklists are to prevent surgical errors, as I said. Here are some examples of surgical errors, preventable surgical errors, which are wrong site, wrong procedures, wrong patient, and also retained surgical items like sponge and instrument or other sharps. Medication error during anesthesia. Secondary is to reduce postoperative complications and infections. Here, we can say that surgical site infection can prolong hospital stay and cause several complications to the patients. So the blood loss and hemorrhage, when are unchecked, bleeding can be life-threatening. So when we didn't check on time, or if we didn't anticipate blood loss, we can end up losing the patient. So we have to be careful on that. Anesthesia-related complication and proper assessment. Here we can say that proper assessment prevent airway issues and adverse drug reactions. The other thing is to improve communication and teamwork. So here we can say that better coordination among surgeons, anesthesiologists, nurses, and anesthesia team and peers, and also to By structured timeout before incision, this prevents misunderstandings and also encourage open discussions of concern before, during, and after surgery. Also, to enhance patient outcome and recovery, here we can say that a few complications will lead to shorter hospital stay, and also to reduce the need of additional surgeries, and to improve overall survival rate and quality of life. So it can also reduce healthcare costs, which means that surgical errors and infection increase hospital costs. If the patient have infection, post-op infection, it will lead to additional costs to the patient. Readmission and prolonged ICU stay, and also prevention is in chapter the treatment. A well-executed safety protocol can save money to the patient. Also, to build patient trust and confidence, patients feel safer when they see that you are identifying and proceed double check on their identification. And also when the surgical team follow a clear safety protocol, and when they open communication and teamwork in the operating room, especially before induction of anesthesia, the patient will observe everything you are doing when you are counter checking on the identification, and while you are communicating with each other, the patient feels safe. So here are statistics on surgical errors and complications, where they say that 38% of patients undergoing surgery experience adverse events, and at least 20% of these complications result from medical errors. 10% of these events were deemed completely to be preventable. This is from the study done in 2024 by BMG. It's a medical journal. The most common complications were surgical procedure errors, medication-related issues, and healthcare associated infection. We have here a case study and evidence that shows that where study shows that 30 to 40% reduction in complication with surgical safety use. It means while using a surgical safety checklist, it reduces more than 30 to 40% complications. And also the implementation in large hospitals reduced mortality by 47%. This was shown in this study done in 2009. So here are the barriers to implementation of the WHO checklist. The first barrier is pragmatic challenges. So where during duplication with existing checklist leading to irritation and checklist fatigue, here we can say time consuming, inconvenient, inappropriate timing, poor communication, unfamiliarity, confusion, and to know who should prompt the item, absence of the key team members, using the checklist as a tick box exercise. Here, they don't give importance on surgical safety checklist. So the attitude also can be a barrier of surgical safety checklist implementation, where they deny that routine tasks can be forgotten. Again, dismissive attitude, lack of engagement, hierarchy in the operating theater, discouraging open communication, embarrassment about introduction, and lack of support from leader or management. So resources also can be a barrier, lack of resources such as markers, pain, antibiotic, and pulse oximeter. All this, there are some hospitals where they don't have much resources, where they can't even find the marker pain, or where they don't have antibiotics. If they don't have all these resources, they may not check, because it will be useless. If you ask that people use things that they don't have, it's meaningless. So lack of antibiotic policy and protocol, no routine swab and needle instrument count. So all these are barriers to the implementation of surgical safety checklist. So next one are the top tips for successful implementation of the surgical safety checklist. First one is the leadership support. So hospital should ensure hospital leadership and senior staff actively support and advocate for the surgical safety checklist use. Allocate resources, time, and training for successful implementation. So when you have resources, and when you give time, and then when you provide training for the team, this will lead to the successful implementation of surgical safety checklist. Secondly, the team engagement and training. We should conduct regular training sessions for all surgical team members to be aware of how and why we have to use a surgical safety checklist. Emphasize the importance of teamwork and communication in surgical safety checklist adherence, and also customization and integration. We have to adopt the checklist for fit the specific need of your hospital while maintaining the key safety components. So the other things is that to integrate the surgical safety checklist into existing workflow to minimize disruption. So clear roles and responsibilities. We should define who will lead and coordinate checklist use in the operating room. We have to ensure every team member understand their role in completing the checklist. Consistent use and accountability. We have to make checklist completion a non-negotiable part of the surgical process. We have to monitor compliance and address gaps through feedback and reinforcement. We have to encourage open communication by foster a culture where all team members feel comfortable speaking up if safety concerns arise. Use this checklist as an opportunity to ensure shared understanding and prevent errors. So, measures and improve. We have to regularly review checklist compliance and effectiveness through audit and feedback. So continuously refine the process based on the team input and patient outcome. By conclusion, we have seen that preventable harm occur daily during surgical across the world. And also, surgical safety checklists are essential for reducing errors and improving patient outcome. The consistent use enhances teamwork and patient safety. And then the ongoing training and adherence are crucial for effectiveness. So this is all. Thank you so much for your kind attention. And these are some references you can use for more details. Thank you. Your question and comments are highly welcomed.
Hello.
Hello.
Hi,
Hello.
Danny.
May I
Good
ask
evening.
a question?
Yeah, I have a question. My name is Olaniyon from Lagos, Nigeria. Can you hear me?
Yes, we can hear you.
Okay. Yeah. Where exactly we need to read the safety checklist for the sign-in? Is it at the induction room or at the waiting area?
Hello?
Hi.
Hi, may I answer this question now?
Okay. Okay. Go ahead.
Yeah, thank you for the question. The
You're welcome.
sign-in is done before induction of anesthesia, depending on the culture of the hospital or the protocol of the hospital, because there are some hospitals where they don't have the induction room separately to the operating room, and other hospitals, the induction of anesthesia are done in the operating room on the operating table. So the sign-in is done in the operating room on the operating table where they don't have the induction room separately. But I think for those who have the induction room, it can be done in the induction room.
Oh, okay. Then exactly.
All right, thank you for a nice presentation. I hope already has got the answer. I would love to start from the chat. Nigel has asked about
Hello? Hello, Florence, can you hear me?
Yes,
Hello.
I can hear you.
Okay, Florence, this is Haile Mariam from Sierra Leone.
Yes, Sema.
Yes, from Sierra Leone. The presentation was nice and very informative. We will appreciate for the presentation.
Thank you.
But I have a bit I can't say it's a question but contributions on the current development of the. May I proceed, Florence?
Hello?
Hello, may I proceed with my contributions on WHO surgical safety checklist implementation?
Yes.
Okay. One current modification on WHO surgical safety checklist is on sign out. Initially,
Yes.
it was proposed sign out to be before the patient leaves OT. So currently, the recommendation is that not before the patient leaves the OT. Rather, the sign out has to be made before closure in order to make sure that all completion of instruments are the same with the timeout. In order to prevent error and missed instrument, the sign out is supposed to be done just before closure, not before the patient leaves the OT. This is the one development, current development on modification of WHO surgical safety checklist.
Thank you.
Two, WHO itself recommend 10 to 20% of modification on the list. As you said, depend upon the culture and the protocol of each hospitals. Okay, so especially for cesarean deliveries, now checklists like fetal monitoring, radiant warmer, suction and oxygen availability for the baby was included from safe surgery point of view. So these two modification has been made as of last 2 years. So most of those people are now recommending using this further recommended checklist. So this is the additional point I have on WHO surgical safety checklist. The rest is very nice. Thank you.
Thank you so much for your contribution. Thank you.
Hello, good evening.
Yeah, good evening.
Good evening.
Good
Thank
evening, Daniel.
you. Jean-Paul speaking. I have questions. Can I go
Yeah,
on?
you're most welcome for the question.
Thank you. Thank you, Sister Florence. The presentation was so precise, it was so informative. But I got 3 simple questions. The first one is about the responsibilities. In one of the slides, when you came toward the end, and the recommendations that there should be assignment of who should coordinate this checklist. So according to experience or to the standards, whom do you think should be the best in coordinating this? Should it be a nurse? Should it be an anesthetist? Or should it be a surgeon? Number 2, I want to know the scope of the surgical safety checklist. Is it applicable to all the patients undergoing surgical procedures? Because there are some cases where we don't have anesthesia, we don't have incision, such as cystoscopy or hysteroscopy, you know. So should we apply this surgical safety checklist? This will be also same as people who work in the cath lab where they do just angiography, you know. So the last not least is about these antibiotics, prophylactic antibiotics. There's some more projects that are being carried on because it has been realized that people are relying to these prophylactic antibiotics and omit more other aseptic principles. And people are developing much resistance to antibiotics. And yet, some researchers are showing that if people could abide by these aseptic techniques and the principles, probably prophylactic antibiotics should not be necessary, and they should not get this surgical site infection. So what is your say? Should we keep this practice of antibiotherapy, or do you have any different view? Thank you.
Thank you, Jean-Paul, for the questions. Starting from the first one, where you asked about the responsible person to conduct the surgical safety checklist. So, as they say, the surgical safety checklist is done. Let me start by the team in the operating surgical team. We have, as we have seen, we have surgeon, we have anesthesiologist and anesthesia technician, we have scrub nurse and circulating nurse. So the circulating nurse is the best person to conduct surgical safety checklist, but the other team members who is able to do it, I can say about surgical anesthesia team can do the surgical safety checklist. But the best person they recommend is the circulating nurse to conduct the surgical safety checklist. So I don't know if there is someone else who wants to comment on that, if I'm wrong, or if there is any additional from the members, but that's how it is done. So according to the patients where we have to conduct this surgical safety checklist, as you said, you say that patient who will not need anesthesia, patient who will not have incision. Here we can say that all patients, we have to do surgical safety checklist for the safety of the patient. First, we have seen that the importance of that is that we have to it's for preventing surgical errors. And among the surgical errors, we have seen that we have to be sure that we have right patient, right procedure, about the surgical site. All this, we have to be sure of them before doing the procedure. So even though we don't need anesthesia, but we have first to identify the patient. Again, we have to know that patient has any allergy on any medication or anything, so that we can be careful on what we are using on patient. Patient can be allergic on latex. All these are examples that why we should just use surgical safety checklists for all the patients. And also we have to make sure we ask the surgeon what is going to do, what procedure to be done. If we have, according to the timeout, we have to make sure we have all the equipment ready, sterile. Even if we are doing cystoscopy or any other procedure that don't need incision, but even this endoscopic equipment should be disinfected before we use them to the patient. All these have to be provided before starting the procedure. And also the instruction post-operative instructions, we have to all this to mention them before the patient leaves the operating room, as we said. So about the antibiotics, it depends on policy and procedures or protocol of the hospital, but the antibiotics should be given to the patient to prevent infection. Here, because you have said that some patients have allergies on antibiotics. That's why before administering any medication or any antibiotics, we should just give a small dose test to see whether patient have allergy on that medication or not. And also, I have seen that there are some surgeons that don't prefer to use the antibiotics. So all this will depend on the protocols of the hospital and also can depend on the type of the procedure that is going to be done, or also when the patient is under antibiotics. All these have to be discussed. That's why we have to have same understanding as a surgical team before starting the procedure. Thank you.
Thank you. Christians. Can I ask the one who make addition? Hello?
Hello?
My question want to be addressed for the one who make addition, and he told us that we have to do sign out before closing the skin. It comes in my mind.
Yes, come please to the question.
Yes, it come in my mind asking myself, if we got a complication and we open again, are we going to start again from sign in, or what next? That's the first question. Then the second question is, as we are doing sign in, we are addressing our question to the patient. Is there a part, as you are doing addition, where we can ask the surgeon to confirm that procedure and even the thing the surgeon will need or other team will need? Thank you.
Will you please come with the first question? You lost between. Please repeat.
Yes. The first question is, you were saying that sign out should be done before closing the skin. Yes? Hello?
Yes, continue. Carry
Hello.
on.
Then my question comes in my mind. If we get a complication and we open again patient who was still in theater, are we going to start again by sign in, or we are going to do again sign out after we close? Thank you.
Okay. Let me reflect on your question, ma'am. Christensen, right?
Yes.
So, as you know, WHO surgical safety checklist has its own exceptions. There are a time which will be exceptional for you to follow all the procedure. Okay? But as the standard, whether you repeat surgery, whether this is the second incision, the third, the fourth, the fifth, you are going to implement WHO surgical safety checklist, because that is the safety assurance of the patient care. You understand? But sometimes you will find yourself a need might arise during complication. Everyone might be ready, saving that patient. So in that instant, you might find yourself difficult to implement WHO surgical safety checklist. But the recommendation is that whatever the instance, you must use the checklist. Okay. So why I say before skin incision, as you all know, we are going to count instruments that we have used Is that not? So instrument count has to be correct enough for you to close the skin. What if you forget gauze? What if you forget one of the instrument like spongy forceps, whatever? That will be catastrophic for you to close the skin and count the instrument. I mean, now better to go sign out just before skin closure. Thank you.
Thank you. I have another question.
Thank you so much for the contribution.
I have another question, which is, when we have like dying emergency, what's the best time to do surgical safety checklist? Thank you.
Hello.
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 Hello. I can hear you. We can hear you.
Okay, you are asking that when we have a dying emergency, when we can do the surgical safety checklist.
Yes.
Yes. Thank you. I think when it's an extreme emergency, I can't say that we can't use surgical safety checklist, but it's up to the team to evaluate and see what's the priority. If it's just first to save the life of the patient, where you can be starting, if it's a induction of anesthesia, like intubation or whatever you can do. But when stable, you can just do the checklist. It means maybe the signing may not be done, but you can continue by doing a surgical count and also respecting all this antibiotic prophylaxis and doing timeout while starting the procedure. That's what I can say, because maybe other team can help us to talk about it, but that's what I can say, that we should not stop doing surgical safety checklists, but we can just evaluate and judge what is the priority, if it's to save the life of the patient first, or if we can just do it quickly and then proceed with the procedure. I think it's we can make.
Hi, Furaha. May I intervene?
Yes, thank you.
I
Yes,
think
please.
with an emergency, a very truly emergency situation, that's where you need a checklist.
Yeah.
That's where you need checklist, because you do not have time to think. You do not have time to just go for something else. You need checklist, cognitive aids, everything that can help you to buy time and save life. That's a dire need of checklist.
Thank you so much.
Thank you.
Sorry, guys, can I have something to say? Can you hear me, guys?
Yeah, well,
yes, please.
Yes.
Can you please suggest?
Okay, so first of all, I would like to say thank you for Sister Florence from King Faisal Hospital for your great presentation. My name is Nur Hussein from Ethiopia. I want to add some points about the checklist because one thing, it is an old checklist actually, and the surgeries that we are doing currently are changing, so we need to change it as per the demands of the complexity of the surgery. One of the disadvantages of this checklist is it doesn't really specify or specifically identify whether it is used for surgical emergencies or for elective surgery. So one of the participants of the meeting said that it's really important that using this checklist is more advantageous during an emergency case than during an elective case. I think I would go with this idea strongly, because the most important thing is to salvage the patient's life, and it should not be that much time taking, and there should be someone who is more capable of reading the checklists very briefly for the team, so that we will avoid complications in emergencies. Otherwise, if it is an elective case, we have time, we have a very blended time, so that we can just use the checklist smoothly, so that we may not even anticipate such great complications as that of their emergency counterparts. So the most important usage or advantage of using this checklist is during an emergency surgery. So I think we need to even adhere to this checklist during emergency surgical interventions. Thank you very much.
Thank you so much for your contribution.
Hello.
Hello.
Hello, Sister Florence. Well done on your presentation. This
Hello,
Belinda
Belinda.
from Ghana. Well done. I would also
Thank
want
you.
to add a few points. I take it from the last two contributors. I think, like we all agree, or the presentation has enlightened us, the basis of this checklist, the fundamental purpose is to prevent errors. So whether emergency or elective, we are expected to use the checklist, and even more so during emergency, because that is when we are under pressure, we are running around, and we are likely to make mistakes. And so even more so during emergencies, we need to use this checklist. What is important here is the urgency we attach to signing in, timeout, the whole process, the urgency with which we do it. So for me, I will not separate. For as long as a patient is on table for a surgical procedure or a minimally invasive procedure, or in that environment, we need to use the checklist to prevent errors and to safeguard our work as professionals. Earlier, somebody asked whose responsibility it is to use the checklist. Safety for our clients and ourselves is a teamwork, as the presentation has enlightened. It's a teamwork, so much so that if we are all intentional about it, it doesn't really become whose responsibility it is. If all of us agree that it's for our safety as well, because if legal issues come, it's everybody within the team in that OR at that particular moment, we will all be in trouble. So for me, in my OR, yes, we leave it open. Sometimes anesthetists help us do it, the surgeons help us, nurses, but most literature will suggest, will give the inclination that the circulating nurse is the one to facilitate that process. But if we all, like I said earlier, are intentional, and the goal is to prevent errors and not to put ourselves into trouble, I think that all of us must be interested in it. Because there are times where the nursing team might be busy, might be overwhelmed. In that instance, I think the other team members can also help in taking us through the process. And to add finally, for me, the 3 phases is a personal conviction anyway. I think the signing in phase is the most critical for me, because literature says it should be before induction of anesthesia, because it is only then the patient can make a contribution in case we get any information wrong, in case any information we have put down about the patient is wrong. That is the only time the patient gets to correct us. So if we skip it, in the case of whether it's a case of emergency or whatever, then we might go through the rest of the phases. But I think that fundamentally, if we get the signing in phase wrong, the other 2 phases are likely to be wrong as well. And I have had a situation where a patient was saved by the bell just because we used the checklist. We signed in. The patient who was supposed to come for a wide local excision of her breast initially had an indication that she was going to have a mastectomy done. But for the timely intervention of us using the checklist, signing in, and patient was awake before we signed in. So she corrected us that no, she's not coming for mastectomy, but she's rather coming for wide local excision and axillary clearance. And we had to get in the surgeon. Lo and behold, that surgeon was not the one who saw the patient. You know, in a big institution where we have other cadres of staff who will prepare patients, who will clerk patients and all of that, it was a resident who prepared the patient, and this was a consultant who was about to operate. And he's never had an encounter with the patient. But for the timely intervention, timely usage of this checklist, we saved this patient from losing her breast. So for me, I think it's a teamwork approach towards this, the use of this checklist. And all of us, all hands must be on deck, and we have to be intentional about it. Thank you.
Thank you so much, Belinda, for the additional.
Hello, I don't know if I can chip in a bit.
Yes, please.
Okay, Florence, thanks so much for the presentation. It was very enlightening. Yeah, so I also wanted to just add a little bit. I know that all along we have always known the 3 steps to safety surgical checklist, which is the sign in, the timeout, and the sign out. But of recent, I know that 2 other steps have been added to it, which is the briefing, which even comes before the signing, and then the debriefing. So we find out that this briefing comes in when all the surgical team come together. They introduce themselves, they go through the list for the day, they talk about allergies, they talk about blood loss, they talk about the antibiotics, they talk about any special thing about the patient, maybe IPC issues and stuff like that. And then the list, if it's going to run as it is on the list, or maybe one will come about before the other, maybe because of health issues, because of age, because of other comorbidities and things like that. So it's a kind of communication um, aid that helps all the surgical members to know about the patients for the day. And then even before we now say, okay, let's send for the patient A or patient B on the list. And after the procedure, before they disperse for the day, we also have the debriefing where they talk about how the days went, if there are learnings from the day surgeries, if there were maybe mistakes, if there were near misses, if there were things that could have been done better, or they did everything as it was supposed to be done. So it acts as a learning process. It also acts as a communication process to help the surgical team members to keep improving themselves. Then in between, we now have our signing that comes before induction, the timeout, and then the sign out. And I want to appreciate our brother that talked about the update in the sign out. I'm grateful that we have started doing it before the skin closure, because let me take, for example, at my own end, because of the quick turnover, you find out that as you close up, you are kind of trying to clear up the patient, clean the trolley, take the patient out and clean the operating room for the next patient to come. So at that point in time, you may miss that sign out. But if the surgery is still going, as you do your swab and instrument count correct, that your sign out should follow through at that point in time, so it's not missed, and then you are not rushing it as it were, because the patient is still on the table and the surgery is still going on. You know that your specimen is there. At that point in time, you can write the surgery that has been done. You can ask the surgeon if there are any concerns for the management of the patient. The anesthetist is still there to say all these things, and not when we are, preparing to take the patient either to extubate. The anesthetist is busy with extubation. That's not the time to start asking, or when they are busy to take the patient to the recovery room. So that update is something I appreciate. Thank you so much.
Thank you so much, Cecile, for the good comments and contributions.
Thank you.
Hello. Thank you very much. Can you hear me?
Yes, we can. Go ahead.
Okay. Thank you very much, our speaker of today. This was very interesting and fruitful presentation. I think we've shared the presentation in chat, and for certification, you will receive a link to fill the webinar evaluation and certification form. Then you will receive your certificate after. I think we are running out of time. I can welcome Dr. Gaston to give us the final remarks for today. Thank you very much. See you.
Thank you.
Thank you very much. Thank you, Wilson. Thank you, everyone, for participating. Especially special thanks goes to Sister Fra. Fra, thank you very much. You did well.
Thank you.
Nice presentation, well organized and concise, and all information that was needed was included. Thank you very much. And the way you articulated was really amazing. We appreciate that. For the first talk with TORG, this is great. And I wish we can get more topics to present next time. So congratulations.
Thank you, Dr. Gaston.
So yeah, I think we had a good presentation, and participants were coming from everywhere, in different countries, and this is really amazing. On behalf of the Rwanda chapter, TORG, it's really good, and thank you guys for appreciating and coming to our presentation. Thank you, Madam President, for always supporting us, every time, every second I see the email popping in, I see the WhatsApp popping in, just reminding us this is a big support for this webinar to happen and to have this representation. Thank you very much. We do appreciate always. Great. So I think for the next webinar, you get communication. Always be aware and check your WhatsApp and check your communication. Communication WhatsApp and everything, so that you don't miss anything. And remember to register fast, register on time, so that you get a link on time. Okay, great. Thank you very much. And I think you have seen the adverts for the upcoming conference in August. You will be getting information about every detail. So keep up and then just try to keep supporting. Thank you very much. Thank you very much. And I wish all the good weekend for everyone. Thank you.
Bye, everyone. Ciao.
Thank you, Dr. Gasto. Thank you,
Thank you very
everyone.
much. Thank you. Bye.